Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, March 24th, 2025. I'm joined today by Dr. Sadia Mobeen to discuss, how do I know if I am in labor? This is a very common question women have at the end of pregnancy, and our hope is that this podcast can be a helpful one for all of our pregnant listeners out there and their loved ones. While it might seem that we are doing this podcast to reduce the number of phone calls we and other obstetricians get at night, that is not true. If you are not sure if you are in labor, best thing to do is not to fire up this podcast. Rather, just call your OB or midwife. All right, thanks for listening. See y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, Dr. Mobeen, welcome back to the podcast. Happy New Year. How you doing?
I'm good. How are you? How was your New Year?
My New Year was uneventful, which is typical as you age.
Exactly. I was in bed before the ball even dropped.
Definitely. That is a Fox tradition to go to sleep well before the new year is ushered in, but all good. So thanks for coming on the podcast. We're going to be talking about a really common question that comes up to us in the office. It comes up when you're on call and you get phone calls, people come in triage, and that's, how do I know if I'm in labor or not? Like, what's the deal? And I guess in your experience, is this something you get asked a lot?
I get asked this I get at least one phone call about this almost every call shift, sometimes more than one. So yes.
And I think that it's fair. It's a fair question. And I don't think we're going to necessarily answer it today because it obviously is individualized. But I think the point is really to help people understand the framework that we use when evaluating someone to determine if you're in labor, so that people have a better understanding sort of what kind of questions we're going to ask, what kind of things would lead us to believe you might be in labor and bring you into the hospital or the office, or if we're seeing you in the hospital, when might we keep you versus sending you home. Obviously, this is not a resource where you just listen to the podcast and know for sure one way or another. And so caveats and disclaimers abound. Ask your own doctor or midwife your own clinical questions. This is just a resource. So the MFMA legal team has now thanked me for putting that out there. So we can begin. I guess as an overview, maybe if you could help our listeners understand how do we even define labor? Like, what is it that starts labor, or that would be the definition of someone going into labor?
Typically for most people going into labor, they would need to have regular contractions that are strong enough to cause their cervix to change, so that way that they can progress and they can give birth. So typically they need to be strong and they need to be at regular intervals as well. And usually labor pain starts lighter and it gets stronger over time, and they usually get closer together and more regular. But the only way we would know 100% if you were in labor was if we did an exam, and sometimes we need to do multiple exams to compare if you're making change or not.
Yeah, that's a really good point, because, the cervix, people can have contractions and their cervix is not changing, and that's not labor. And their cervix can change over the course of pregnancy or towards the end and not have contractions, meaning you can go from being closed 1 week to 1 centimeter dilated the next week without having regular contractions. And that's not labor as well. You really need both of them happening together. And you don't always know, right? If someone comes in and they're contracting regularly and they're 1 centimeter dilated, I don't know if they're making change. I would need to check them a few hours later to see if they're now 2 centimeters dilated. And so sometimes we don't even know unless it's in retrospect after examining them multiple times, like you said. So even when we evaluate you, we don't always know. We're sometimes just taking our best guess. And certainly someone at home wouldn't know if their cervix is changing. There's no symptoms to your cervix changing. You just feel the contractions. And that's really what most people are going by at home.
Exactly. Well put.
And then there is another sort of option, which is like a parallel conversation, which is some people, when they go into labor actually it does not start with contractions. It starts with their water breaking. So talk about that a little bit.
But typically 10% of people's water will break before they go into labor. And that's like pre-labor rupture membranes. Normally it happens because the membranes it's like a physiological process where the membranes weaken towards like once you're past term, closer to your due date. And sometimes you can be having some contractions that may not be as strong, like possibly Braxton Hicks, where that can cause the force of that to cause your water to break. If that happens, then even though you're like not having any symptoms, we would recommend that you come in and be evaluated, because most people will eventually go into labor, usually within 12 to 24 hours of their water being broken. But if your water breaks before your labor starts, we would recommend that you come in and be evaluated, because the longer your water is broken, even if your labor hasn't started, there are risks associated. And then that's why we have that conversation about if your water is broken, what to do next in terms of options. We talk about, the recommendation usually is that if your water is broken, you should come in and we should help your labor start. Sometimes we have a conversation where when should we wait a little bit versus to see if your labor will start by itself versus if we should help you along. But that's like a parallel conversation. Like you said, it just depends on what your initial symptom is when you call.
Right. So we're going to talk about those two scenarios separately. So scenario number one is sort of what most people experience when they go into labor, which is first they get regular painful contractions that causes their cervix to change. And then eventually in labor, their water breaks, or sometimes we break it for them in labor. So that's scenario number one, which is more common. And then scenario number two, which you mentioned is about 10% of the time, is first the water breaks, and then either someone goes into labor on their own or we help them along and they go into labor. So let's talk about the first scenario, which is contractions starting first. So when do contractions begin in pregnancy for most people?
They usually begin anytime in the third trimester. They initially will start off as pretty mild and irregular. A lot of times you'll have those weaker contractions to help your cervix soften over time and then help it thin out to get your body ready for labor. And that's why, we always ask questions when people come and say, I'm having, sometimes they can have tightening, sometimes mild cramps. We typically want to know, how often they're having the contractions, how strong they are. If they can, usually I'll ask them if they can walk and talk through it, if they're able to sleep through it, how many seconds it usually lasts, and if it's getting worse over time.
Yeah. And I think also some of this evaluation is a little bit different based on when these contractions are happening, because very many people have contractions throughout the third trimester, and the questions we ask might be different and our evaluation might be different if someone is preterm versus full term. Meaning if someone is, let's say, a week before their due date, they're 39 weeks, and they tell me they're having a contraction, every 10 minutes or so. At that point, all right, I don't think they're in labor. And I usually tell them, not much to worry about and, go through a few things. But basically, we usually tell them to stay home. Whereas if they were 29 weeks, right, and they're quite premature, we generally would take that a lot more seriously, because even though it doesn't sound like they're in labor right now, that is something that's a little bit unusual. And we often will bring them in to be evaluated. Again, it depends on the exact circumstances and how painful the contractions, what their history is, this and that. But we certainly will think about it differently. So in terms of contractions, it's also important when evaluating, is it normal? Is it not normal? How far pregnant you are? Because as you get more pregnant towards the due date, it's typical that you're going to get more and more contractions, which is a normal thing. But it's not that typical to have more and more contractions in the preterm period. They get them from time to time, but not typically regular contractions. That's an unusual thing, I would say, for most people. Some women get them, but most don't.
I agree.
For someone who's, let's say, full term, right? So let's only concentrate on someone who's 37 plus weeks. So we're not going to focus on the preterm labor evaluation. So someone who's full term, a lot of people ask me, are these real contractions? Are they fake contractions? Are these Braxton Hicks contractions? How do you differentiate those or explain that to people? Because that's a very common question that people ask.
So what I typically say is how you can tell the difference. I usually tell them that it's normal, like your term, your body's going to start to contract. Typically, sometimes you'll have back pain, sometimes you'll have mild cramps, your belly will also tighten. Typically, how you can differentiate between a labor contraction and Braxton Hicks is a labor contraction kind of like knocks the wind out of you, stops you in your tracks, usually lasts anywhere from 60 to 90 seconds. You're not able to like talk or walk through it or sleep through it. If you're having those, then you should start timing them to see how far apart they are. Typically, you need about 3 to 5 contractions in a 10-minute window to cause cervical change. But I usually tell them to call if it's their first baby when they're about 5 minutes, when they're contracting about 5 minutes apart for about an hour.
Yeah, I don't know who Braxton and Hicks were, but they got some serious name recognition for contractions. And essentially, people ask me, like, what are Braxton Hicks contractions? And what I typically tell them is Braxton Hicks contractions are essentially contractions where you're not in labor. And so it's probably a lot of people might use them synonymous with false contractions or false labor, or, people have a lot of different names for it. But basically, the uterus contracts. It's normal to contract and at different frequencies. And before you're in labor, they're just contractions. And then once you go into labor, we call them, full labor. And that tipping point is usually gray for people because they don't know, again, when their cervix is going to start to change. So what you were saying is one of the ways people might know is how painful they are and how regular. Meaning Braxton Hicks don't tend to be very painful and very regular. They could be, but they don't tend to be. And so, but when someone's in labor, that typically happens. Now, what about going to the other side of the equation where someone's water breaks before they go into labor? How would someone know that their water broke?
Usually, most of the time, they'll have like a large gush of fluid where they'll either like soak their clothes or wake up with like the couch or like the bed being soaked. That's the obvious way to know. Now, other times, patients can have like a small gush of fluid where they're not sure if their water broke because a lot of times it's common for pregnant women to pee on themselves, have some increased discharge. So it just depends on when they call, what they're describing. If they describe the first scenario where they have a gush of fluid, it's highly suspicious. So we recommend coming in and being evaluated. Now, with the second scenario, if they're unsure, what we usually do is 1, we offer them either the option to come in for an evaluation, or 2, we usually will tell them to put a pad on, walk around for 30 minutes to an hour. If your bladder is broken, you are going to continue to leak. So if you end up soaking the pad, likely your water is broken and you should come in to be evaluated, is what I usually talk to them about.
And then if you're going to evaluate them, what is the evaluation you do to check if their water's broken?
So typically have them come in to the office or the hospital. I start off with a speculum exam where I will place that metal speculum that we use when you go to any gynecologist's office. And we will typically look to see if there's fluid in the vagina. Sometimes I'll have them cough if I don't see any. Then we do other tests, such as we have this stick that we place that turns blue if you have amniotic fluid in the vagina. Then sometimes we will do a sonogram to check the fluid to see if the fluid level has dropped significantly from their last visit. We also will sometimes, if we see fluid, place it on a slide and look underneath the microscope to see this tree-like pattern. So just different tests that we have that will help us like evaluate. And depending on what we find, we would determine if the water is broken or not.
So let's go through a scenario for our listeners. Let's say you're on call and it's, 11 at night and someone is not sure if they're in labor, right? They're full term, they're having contractions, and they're not really sure whether this means they're in labor and they should go to the hospital or whether it means they should stay home and wait. And so they call the office, they get you on the phone through the answering service, and you pick up. What are the questions that you're going to ask them? And I'm going to give you like some of the answers and to help understand what are the things we'd sort of bring you into the hospital for. One of the things we would tell you to stay at home. So like, what are the questions you would ask someone who's saying, I'm full term, it's my first pregnancy, and I'm not sure if I'm in labor?
So I ask them if they're having contractions. I typically will tell them they're like usually cramps, painful cramps where you're not able to like walk or talk through them. That's usually my first question.
Okay, so let's say they say, yes, I think I'm having those. They're pretty painful.
How often are you having them?
So let's say they said every 7 minutes.
Okay. And I would ask how often how long do they last?
Right. So let's say they last, I'm not sure how long they last.
But they're about every 7 minutes. How long have they been going? How long have you been having contractions?
I've had 2 of them.
Okay. So in this situation, I would typically say as long as the baby's, I would also ask if she had any vaginal bleeding or excessive fluid, like her water broke.
Right. And so let's say no bleeding, and I don't think my water's broken.
And I would ask to make sure is the baby moving like normal?
Baby's moving great.
So what I would say is, because it's your first baby, your term, your body's probably starting to contract. It's normal, for that to happen. What I would recommend is, continue to monitor at home. Once you start having these painful contractions about every 5 minutes for an hour, then give me a call back, because at that point I would bring you into the hospital for an evaluation.
So the threshold of contractions about every 5 minutes for an hour. So just to understand, what is the reason that we would use something like that? Like, why would they have to be going on for an hour, and why should they be every 5 minutes apart? And are those sort of like hard lines, or are those just sort of, averages?
They're just averages. Typically you need about 3 to 5 painful contractions to cause cervical change. Sometimes depending on where the patient lives, they may take them a little while to get to the hospital. So usually by the time they get there, then if they're 5 minutes apart, then they should be getting stronger and closer together. So the theory is, by the time they get there, that they'll be stronger and closer together. So that way, more likely a chance that they'll be in labor but it's not, an exact science. It's just depending on how much pain the patient's in. If I hear that she's visibly in a lot of pain and cannot tolerate it, then I may offer an evaluation sooner or if the contractions have been going on every 6 minutes for the last hour, then I may, say, if you're really uncomfortable, just come on in.
Yeah, I think that's a really important point, that it's not that there's a rule that you can't be evaluated unless you're having a certain threshold of symptoms. It's sort of, the principle is the only way that you or I are going to know for sure if someone's in labor is we see them, we examine them, we figure out exactly what's going on. But that requires someone to, get up, get out of bed, get to the hospital or the office or whatever it is. It might be the middle of the night. If they have other kids at home, they got to, get someone to watch them. There's effort involved in this. And a lot of people don't want to do that to find out, hey, I'm not in labor, go back home. And so not everyone feels exactly the same about that, right? Someone who lives very close to the hospital might be, on the one hand, more comfortable waiting at home, knowing, hey, I'm going to make it to the hospital either way, I'll be fine. Whereas they also might be they might desire to come in because hey, it's no big deal for me to come in and get checked. So I'd rather just know and find out. So it can go in both directions. Or on the flip side, someone who lives very far away, they might really hesitate to come in because they don't want to go in and go back. It's such a long trip. On the other hand, they might say, I don't want to go into full-blown labor and deliver in the car. And so people's circumstances will affect this. And obviously their own concerns, their own anxieties, their own fears will do that. And so and also how they're experiencing the pain. Someone says, these contractions aren't that painful to me. I'd rather stay at home a little bit longer. Again, assuming everything else sounds fine, we're going to give them a lot more leeway with that than if they're, in horrible, horrible pain. They're like, I want an epidural, yesterday. Then obviously we're more likely to bring them in. So these rules that people hear and we say, and this or that, they're, like you said, they're not hard rules. They're just sort of guidelines where if you're contracting painfully, like you described before, where they sort of take your breath away, they last 30 to 60 seconds, they're regular, they're every 4 to 5 minutes, and they've been going on for an hour, the odds are you're in labor if you're full term. Not 100%, but the odds are. So if you come in, the chances are you're not going to get sent home, right? No one's going to say, hey, your service is closed, you're not contracting, go home. Whereas if someone's contracting not so painfully and they're 10 minutes apart and they've only been going on for 30 minutes, there's a pretty reasonable chance if you come in, you're not in labor and you're either going to be sitting around for a long time or you're going to need to get induced or you're going to go home. And so that's sort of the reason these things came about. It's not like that there's some rule that we're not allowed to evaluate someone before a certain time and we have to evaluate someone after a certain time. And I think that sometimes gets lost in the marketing around these rules. I mean, I assume when you're on call, you have people who come in earlier than you normally would and people come in later than you normally would based on their circumstances.
Yes. So I always will always offer them if they want to come in. I'll tell them like if I think they need to, but if they want to, I will always, offer that to them if that makes them feel more comfortable to just come in and be evaluated.
Yeah. And it's the same thing. Like, people ask me, when should I call? And again, it's not like, and I tell people, these are the phone calls we take. Like when you're on call for an OB practice, many of the phone calls we get are, hey, I'm contracting, should I come in? Or, hey, I'm not sure if my water broke. Like this is very, very typical. And we're very comfortable walking people through that. And so we give people some basic structure to that, some, not really a guideline, but just some basic information. So they sort of get a sense of, this is the time we're probably going to tell you to come in. And this is the time we're probably going to tell you to stay home. So you don't need to call us if you're contracting every 15 minutes and they're not very painful, but you're obviously welcome to if you'd like to. And we're happy to talk about it and figure out what's going on. And so again, all of this stuff is really meant to just be helpful, not really like rules, so to speak. Let's go to the other scenario. Someone calls you and says, hey, I just woke up and I'm a little bit wet and I'm not sure if my water broke.
So I would ask them how many weeks they are.
Right. So let's say we're full term first baby.
That's right. Okay. So I would ask them, one would be, what time did this happen? And how much fluid did they notice?
I just woke up. It happened 15 minutes ago and it was enough to, I don't know, there's a little tiny puddle under me, maybe the size of a few inches.
Okay. I would ask them like, what color is it? If there's any odor or smell to it.
Not that I can tell.
Okay. And any vaginal bleeding?
No bleeding.
Okay. So in this situation, I would talk to them about, there's a chance that your water could be broken. I would also ask them if they're having any contractions.
Not really.
Okay. And I would also tell them that there's a chance their water could be broken, but, since there's a small amount of fluid, they're not sure. I would talk to them about one, either coming in to be evaluated, or two, putting on a pad and walking around for about 30 minutes to see if her water is broken. She's going to continue to leak fluid to see if she's leaking fluid.
Right. And what is the threshold where you would say, oh, that sounds like enough that your water's broken, just come in? Like, is there like something you have in mind, or is it just sort of you get a sense from what they tell you?
It's like case by case, depends on what they tell me. Sometimes if she told me she had a gush of fluid, if she was awake or like she was walking, all of a sudden had a gush of fluid, sitting on the couch, had a large gush of fluid, that's pretty accurate for having your water broken. Sometimes they'll say they have like a small amount of fluid, they're not sure. Then in those situations, I would recommend them monitoring and putting on a pad. But just depending on what they tell me, there's no like hard or fast rule. It just depends on like what number baby it is, how far they live, their history. And then if they want, I always offer them to come in and be evaluated. Sometimes they live far away. They necessarily don't want to have to come all the way here for me to tell them they have to go home. So in those situations, I would be more likely to have them monitor. But usually we'll just follow up with them in like 30 minutes to an hour just to see what's going on. And depending on what is happening, if they tell me there's like a little bit of fluid on the pad or they soak the pad, then of course I recommend that they come in and be evaluated.
Yeah, I mean, I agree. I mean, I tell people that usually, I would say 90% of the time, it's pretty obvious, right? When someone calls,
exactly,
whether their water's broken or not, to say, I got a big gush, my socks are wet, like they're like, hey, there's nothing else that could possibly be going on my water break. Say, okay, come in. And, every now and again, we're surprised and their water didn't break, but almost always that's a pretty, surefire sign. And on the flip side, if they say, I have a tiny bit of mucousy discharge and nothing else has been leaking for the past hour, it's pretty obvious their water's not broken. Maybe 10% of the time, it really is hard to know based on the story. It could be, a slow trickle of fluid. It could not be. And we really have no way of knowing unless we bring him in and check him out. But I'd say usually we can figure it out over the phone and get it right. Usually, not always. So let's say the scenario's different and you're not on the phone. You're actually seeing them in person in the hospital. So you mentioned before what you would do if we're trying to figure out if their water's broken. What if someone, they come into the hospital, they are contracting, let's say painfully, every 4 to 5 minutes. So that's correct. And you examine them and they're 1.5 centimeters dilated. How do you figure out if they're in labor or not at that point?
So first, I would check to see if they had an exam earlier in the office, earlier in the week, to see if I have something to compare it to, depending on what the exam was earlier and how long ago it was. And I will also see how painful the contractions are, how, if the patient wants pain management. Typically, between early labor, there's options of like IV pain medication versus epidural. And then I would talk about, since she's only 1.5 centimeters, the option to have, another exam in about 2 to 3 hours to see if there's change being made. If there is, then she's likely in labor and should be admitted. If there is not, then likely it's like early latent labor / like false labor pain. Now, everybody has different like pain thresholds. So even if there's no change and the patient's very uncomfortable, depending on how many weeks she is, there's always, 39 plus weeks, there's always the option to stay and get pain management, and we can, help you with the labor process by inducing you. But most of the time, it just really depends on what the initial exam is and the comparison to the second exam.
Yeah, it underscores that there's a lot of gray in terms of, number one, when exactly is labor starting? Did it start with the contractions? Did it start when you actually can tell that the cervix is changing? Because it changes very slowly in the early part of labor. So you can check someone, over 2 hours and have the cervix be the same, but then find out later they probably were in labor. Or, if you check someone at 7 a.m. and they're 1 centimeter, and at 9 a.m. they're 1 centimeter, and at 11 a.m. they're 2 centimeters. Well, does that mean they went into labor at 9? Were they in labor at 7, but it took some time? It's very hard to know this, and that's well known. And so that's sort of gray area number one. And gray area number two is, does everybody in early labor need to be in the hospital? And the answer is no, right? There's people who labor at home for some time. There's people who labor and deliver at home. There's people who, there's all different forms of things that happen. And so for people who are planning a hospital birth, like in our practice, we do hospital births, whether they need to be in the hospital, a lot of it sort of depends on the circumstances. One of them is obviously, how's the baby doing? How's the mother doing? How's her health? All these things, fine. But also, how much pain is she in? And if she's like, I'm not in that much pain, I think I'd be more comfortable at home for the next 3, 4, 5 hours, whatever it is, and the baby looks fine, that's certainly reasonable in very early stages of labor. Whereas someone said, I'm not comfortable at home, or I don't want to be at home, or I'm in enough pain that I want an epidural or something, then fine. Then we admit them to the hospital. So you could have 2 patients with the exact same stats, let's say, for their labor, one of whom goes home and one of whom stays in the hospital. And that's totally reasonable. And so we try to individualize it, and we don't have hard and fast rules exactly about who needs to be in the hospital and who doesn't. Again, assuming the baby's well and the mother's well, because those are other reasons to stay in the hospital. But just in terms of labor, and that's a conversation that we have. And in your experience, when people come to the hospital and they think they're in labor, how many of them are looking to go home for a little bit more? How many of them are looking to stay? Or is that just very, very individualized?
It's very individualized. It really just depends on how much pain they're having and how much they can tolerate, and also their desire for a more natural birth versus like if they are okay with us augmenting / inducing. It just depends on the person, honestly. Everybody's different and it's very variable.
Yeah, and that's also sometimes, like you said earlier, part of the decision we have on the phone, whether to bring someone into the hospital, is sometimes based on that as well. If someone's like, hey, I was planning to labor at home as much as I could because I'm more comfortable here. And then we would probably bring them in a little bit later, again, assuming there's no bleeding, assuming their water's not broken, assuming the baby's moving, things like that. We would say, all right, you wait a little bit longer, and how far they live from the hospital and all those things. Whereas someone is like, no, I am not looking to labor at home. I'm looking to labor in the hospital. I want a nurse with me. I want an epidural. Fine, then come in maybe on the earlier side. And so these things really are individualized. And I think that that's one of the takeaway, points of this podcast, is that there's things we use to help evaluate on the phone and in conversations and in person. But ultimately, there isn't one way to do this. And a lot of it depends on the patient's circumstances and her desires and her pain level. And we try to individualize it as best as possible for her to sort of match what's going on with what she'd like to go on.
Exactly.
Beautiful. We covered earlier a little bit about if someone's water is broken, and that's a separate podcast. But yes, you are correct. The typical recommendation for someone whose water is broken is to come in and have the baby to be, it's not technically being induced because your water is broken. We call it to be augmented. It's its own separate podcast, why that is and what the risks are of not doing it. It does not tend to be a life or death decision, but it is something that is typically recommended. And we do in our practice as well. Again, but that's also individualized to some degree. Dr. Mobeen, good stuff. Thank you for clearing that up for us. And now that everyone's heard this, they'll either be calling you more or less based on how they view this podcast. But thank you for your sage advice.
You're welcome. Thanks for having me on.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.